Hi everybody. Can you hear me?
Yes.
Yeah. Okay. I'm a patient with rheumatoid arthritis, and I'm really going to talk about my journey and the introduction to digital technology as well. I'm going to focus. I've had rheumatoid arthritis for about 13 years. I'm relatively well controlled at the moment, but it's such an unpredictable illness or condition that I might go to bed at night absolutely fine. I wake up in the morning with severe pain in one of my joints. So it is very unpredictable. And on a good day, you're fine. On a bad day, you forget when you have a good day. You forget about all the bad days when you have a good day. So it's up and down. And I was recruited onto the study that I'm going to talk about, Rheumatoid, via a clinic appointment. As well as being a patient with rheumatoid arthritis, I'm also the co-lead patient partner for Rheumatoid. I'll say a little bit more about that later. It's a group of patients who get together and form an advisory group. And my colleague Rupa is also on the advisory group. And we advise on things like patient-facing documentation. We talk to the researchers about the kind of things that affect us, that are important to us as patients with rheumatoid arthritis. And hopefully we work very well. So I'm going to talk about patient perspectives, really, that identified during my experience. So I'll put up two definitions. I apologise for all the clinicians here, but just a reminder of what rheumatoid arthritis is. Okay, I won't read them out. But then I will talk about my experience in outpatients. So as a rheumatoid arthritis patient, you attend an appointment about once or twice a year, probably 6 months or a year if you're well controlled. Before your appointment, you're sent a letter saying you've got an appointment on this certain day at this certain time. If you don't attend, it costs, I think it's about £160 they quote, if you don't attend. Changing the appointment if you've got commitments is an absolute nightmare, but I won't go into that. But that's sort of the introduction to an outpatient appointment. So you arrive at the hospital, you've queued to get into the car park, which is full. So you've driven round and round because all the outpatients are together, you know, all the outpatients clinics are together. You queue, you drive round and round, so you're a little bit harassed at this time. Then you get in and you have to register for your appointment, and you queue again. And again, it's a particularly busy time because everybody else is queuing as well. Then you wait in clinic, and the clinic's running late. So you're probably there, you know, already for about an hour and a half or so. Nobody's full. So at this stage, you're getting fairly harassed. So again, it's stressful, that's what I'm saying. So you get in to see your clinician and you can't remember anything. Your mind goes absolutely blank. So then I was introduced to the study, and we had to download an app. I'll tell you a little bit about the study. We do have a stall outside, Rheumatoid, and it actually shows you the app if anybody's interested, and the symptoms that patients put in to the app. So you're obviously recruited onto the study, following ethical procedures, etc. You can either go into a normal standard of care group or a patient group who uses the app. And I was chosen to use the app. So the app is recorded either daily, weekly and monthly, and you put in different symptoms for each one. You're asked about your pain and fatigue. The symptoms were very carefully organised in relation to talking to patients about what was important to them. So pain and fatigue, morning stiffness, this is daily, so you put in your symptoms, whether you suffer from morning sickness, etc. How you slept, what your well-being is, how you are, how you're actually coping and what your function is at the time. And there is an optional diary. My biggest regret is that I didn't use the diary more because you forget. Okay. So you put in your weekly symptoms. It takes less than 2 minutes to put in your symptoms into the app. On a weekly monitoring, every week you get another reminder asking you if you've got any tender and swollen joints. So you put in whether you've got any tender and swollen joints during the week, the previous week. And then the monthly is tracking disability and impact of your rheumatoid arthritis on your well-being, if you like. So then you go into clinic. Now, the idea of Remora 2 is that the symptoms that you've been putting in every day into the app are then integrated into your healthcare record. So the clinician, when you see him, has a complete record, a 6-month record of how you've been every day during that 6-month period. So when you go in and your mind goes blank, it's very nice for the clinician to then say, well, you know, I can see all your data. And for me, it actually identified the trends through time, the 6 months that I wasn't aware of. I'd forgotten the flares. I'd never realised that I'm never completely pain-free. On a scale of 1 to 10, it's usually about 1. There's always a niggle somewhere. So it's really, really good from a patient perspective to actually have this data in front of you and identify the trends throughout the previous 6 months. And it's much better than a clinician say to you when you go in, how have you been? And your mind goes blank. And you say, oh yeah, I've been fine. And he says, that's not what your data says. And you look at the data. So I've actually identified that I don't sleep very well. I've never been completely pain-free. I do suffer from fatigue, all the typical symptoms of rheumatoid arthritis, but it actually enables me to help manage my disease a bit better than I would have done had I not known any of these things. And it gives also, because all the data is there in consultation, it gives me more time to discuss things that perhaps wouldn't come up if the clinician is trying to get out of you, how have you been in the last 6 months, and you can't remember. So there's a certain amount of probing that goes on. But I think it's really important to remember that patients aren't the same. Patients are all different. I'm an advocate for digital recording, but there are some patients who do not wish to engage at all. They don't want to be reminded of a condition every day to put in their symptoms into the app. And they just will not engage, they just won't entertain it. So that's really clearly got to be recognised. And I think as a patient partner for Remora 2, I just talk about some of the preliminary findings from the study, in that generally patients are quite positive about using the app and going to see and improving consultations and things like this. It definitely helps with symptom recall when you're in a clinic appointment. It can identify the health trends and how you've been over this 6 months. And it also, which is really, I think, important in a chronic condition, a lifelong condition, is that it enhances shared decision-making with the consultant, and it helps with a sense of control. When you're diagnosed with rheumatoid arthritis, you feel that you've lost control. Okay, you can't control it at all. So really the challenges and considerations for the future is that, again, it's the burden of tracking the reminder of disease for some people. There might be an anxiety and over-focus on the disease, whereas you can just try and forget it if you're not reminded constantly to fill in the app. You can get confused with different pain types. The pain that you experience might not actually be rheumatoid arthritis pain, it might be caused through something else, so you're putting in inaccurate data. You might actually record lower pain scales than you're actually experiencing. If you're in a stable condition, it's a reminder every day, and you feel that you're putting in the same data every day because you're stable. And people might not like technology. You might be a technophobe and you just don't, or you might have difficulty with technology. So all these things are sort of findings from patients who have been on the Aurora study. But I think if I just finish with the potential, I think the potential is really, really good. And I'm sure that some of you have got ideas about how you can see this technology working in the future. Hopefully you come at it during the afternoon.
I'm Charlotte Sharp, I'm a consultant rheumatologist at Manchester Royal Infirmary, and I'm a health services researcher. I've been working with Karen, Will and Sabine on Remora for the last 10 years or so. So before I see a patient like Karen in the outpatient clinic, I will spend 2 or 3 minutes just pulling together some information to inform that clinical consultation. So I'll usually look at the last clinic letter that I've written to Karen or somebody or another patient, which summarises their condition, medications, and what we plan to do together at the previous review. I will look at the notes from my nursing colleagues who might have had contact with her in between times. I will look at blood tests and imaging reports that might come through. Data generated through remote monitoring that's then integrated into the electronic health record as it is with Remora, which comes into GMCR. I can view it within the same pane as I do Epic at MRI, means that I'm now able to view what's happened to the patient in the preceding 3, 6, 12 months before I've even seen them. And that's the only opportunity I have to see patient-generated data before I've seen the patient come into the room. So it's actually quite a big shift in the paradigm of the information that's contained within that electronic health record, which otherwise is only kind of created by healthcare professionals. So once we've got that information, what it does in the clinic room is it helps me to agenda set with the patient. So we have very little time, as you know. The patient may have forgotten what's happened to them in between times. So that information helps the two of us to work out what is important to address in that clinic. It helps me to meet my patient's expectations, which is what I really want to be able to do. And it provides a shared source of understanding where we can debate how they've been, we can identify trends in the data, along with all the other information I have, like blood tests, to help me understand is it due to inflammation or something else that's happening in their life. So as well as being a clinical rheumatologist, I'm joint clinical lead for 2 rheumatology sites in Greater Manchester. One is a tertiary complex vasculitis and lupus centre based just down the road in Manchester Royal Infirmary. The other is a secondary care department caring for a really deprived population in North Manchester. And we're under a lot of pressure. Wajid says the NHS is bankrupt, which I experience. It's a difficult context we work in. There are huge backlogs. We've got pressures on personnel, on actual physical clinical space, and we need to innovate to help us to manage the demands of the service and to meet the needs of the patients and the population. And remote monitoring has the potential for us to do that in a time-sensitive and responsive way for our individual patients. If we're able to do this well, we can help patients identify when they might be going to have a flare, provide information to help them manage that at home, and then hopefully get into the system at the time when they need to be seen. So that sounds really lovely. There are a few things that we need to work together on to help us make that happen in practice, to be done in the best possible way. So we've talked a bit already about innovative service models. What does that look like? The model Will described at the beginning, 3, 4, 6, 12-month appointments, doesn't really work for anybody. It doesn't work for clinicians, it doesn't work for the service. I don't think from what Karen's described that it really works for people like her. But we really need those service models to reduce work or remove work, not just add work on. And we do experience digital technologies adding work, creating more and more ways we can be contacted, which just creates additional burden rather than taking it away. We need to safeguard important elective work. So the traditional model for someone with rheumatoid is that they would have an annual review where we review their cardiovascular status, their bone health, their risk from infections due to the immunosuppression medication that we give them. But if you only create a system that only responds to urgent clinical need, then you remove the opportunity to do that preventative work. So we need to build in the prevention work as well as the rapid response. We need inclusion, and I've very purposely not written digital inclusion. We do need digital inclusion, and we also need to admit that not everybody wants to do that right now. Maybe in the future there will be a magic world where everyone wants to and can access digital in the way that would suit us. But at the moment that's not the case, and we really need to work hard to bring people in where we can and support them not to feel like second-class citizens if they're not willing or able to do so. We need people who understand all of these aspects, which I know that many of you do in the room. I'm probably teaching you all to suck eggs. But we really need people to implement systems well, thoughtfully, to support people, patients, to be able to manage their patient portals, to enable the clinicians to understand what the patient portal looks like, for you not to have to be a patient in your own organisation to really have a good grip of what that can offer people. And think about the wider ecosystem, not just funding and secondary care and what that says primary care, as Sabine was asking about earlier. And then finally, we need research to help us understand what works where, when, why and how, and to push us to consider how we might do even better in future.